Reducing patient-related falls by implementing fall prevention precautions. Introduction. There has been an increasing number of patient-related falls in the 3rd Medical Surgical Unit. The unit is currently divided into 3 wings: East, which consists of orthopedic and spine patients; South, which consists of general surgery; and West, which also consists of general surgery. This project is about reducing the number of falls on the 3rd Medical Surgical Unit by reinforcing current fall precautions and adding new fall prevention interventions. There are already fall prevention policies in place. However, current interventions are ineffective in reducing patient falls. Nurses can act as leaders at the bedside by hospital leadership support staff in taking initiative to reduce falls, approach the issue from a teamwork perspective to collaborate care with all staff, determine staff education and integrate latest evidence-based practice on fall prevention, demonstrate shared responsibility and inspire individual liability in preventing falls, increase nurse-patient communication. The Fall Prevention Team. DINA, Quality Improvement Nurse. Data analysis reviewed patient charts and provided hospital data on patient falls. Resource for coming up with interventions to decrease patient falls. Margarita, Assistant Nurse Manager. Resource for budget and material. Help facilitate fall interventions implementation. Encourage individual ownership and accountability for patient safety and quality. Rosa, Nurse Educator. Provided education to all staff on fall prevention, review current policies on fall, recognize the need to update fall policies. Linda, AM Shift Floor RN. Rounding on patients in the morning shift, reviewing charts, resource for implementing new fall precautions. Donna, PM Shift Floor RN, patient room rounding to ensure all nurses are utilizing fall prevention precautions, educating patients and family members on evening shift. Jennifer, Evening Shift Floor RN, implementing new fall precautions, placing signs of fall precautions in patient rooms and ensuring all supplies available for staff. Elsa, Night Shift Floor RN, patients room rounding at night time and reviewing documentation on current and previous falls. Aim statement and expected outcome. Our aim is to reduce patient-related falls in the medical surgical floor by reinforcing current fall precautions and implementing new fall prevention interventions. And specifically, we want to reduce patient falls to 25% by April 30th, 2018. As a result of our project, we hope the newly implemented visual aid are being utilized by all staff in reducing the number of patient falls. Thus, by preventing falls-related injuries and lengthy stays in the hospitals. Improved compliance across all staff and more whispered awareness will result in the reduction of patient-related falls. Diagram. Material consists of availability of bed, chair, alarms, appropriate fall signs, fall visual aids, fall prevention handouts. Equipment. Patient attached to IV pumps, PCA, epidural, Foley catheter, SCD pumps, wound vacs, change in room lighting at night, bedside commode availability, mobility aids, use of nightlight. People. Orthopedic, oncology, spine, medical. Confused non-compliance with call light usage, unsteady gait weakness, perception of ability to mobilize, pain medication, diuretic, laxative, education and communication, lack of knowledge of fall risk patient, failure to notify patient and family of patients at fall risk, lack of education on the use of bed chair alarms, lack of education of all appropriate fall risk signs, education of bed equipment alarms, lack of fall risk teaching to staff, patients, and family not aware of precautions. Environment. Clutter room with excessive furniture, wet slippery floors, trip hazards, fall risk patients too far away from station. Systematic approach. Fall precautions not initiated upon admission, patient left alone in the bathroom, not responding to call light on time, patients charted at risk but no fall precaution in place, no skid yellow socks not in place, nurse did not attend patients fast enough, call light not within reach, patient evaluation not ordered. The change concept. Assessing the current fall data on the unit, fishbone diagram and post-fall assessment, we realized that each and every fall was unrelated. Between the months of September 2017 to January 2018, we had a total of 12 falls on the unit. These falls were related to patient perception of ability to mobilize, patient not aware of at-fall risk, and staff not knowing patient's mobility status. The fourth mentioned reason for patient fall are preventable with consistent staff education on current fall prevention precautions and incorporating new visual aids. Each year, 1 million patients fall in American hospitals. Close to 1/3 of those falls can be prevented. It is estimated that 30% of older adults aged 65 and over fall at least once a year. There is evidence in the falls prevention research literature which suggests that in excess of 50% of potential fall relating to older adults are avoided as a result of ongoing fall prevention intervention. An estimated of 25,500 Americans died from falls in healthcare and community settings in 2013. Countless more suffered life-changing injuries such as fractures, internal injuries, and traumatic brain injury. Experts estimated that more than 84% of adverse events in hospital patients are related to falls, which can prolong or complicate recovery. In the hospital, fall occurs at an estimated rate of 8.9 per 1,000 patients a day. About 30% to 50% of these falls cause injury. Falls increase hospital stays and may necessitate a long-term stay. As you can see in the presented graph, from September 2017 through January 2018, total of 12 patient falls occurred. After implementing the changed project, falls reduced to 0 in the month of March and April. Current fall prevention interventions. SCHMID risk assessment upon admission, fall risk precaution if SCHMID score of 3 or greater, fall prevention handout, bed and chair alarm plugged into call light, hourly room rounding, marked as fall risk on patient's care board, yellow socks and ID bands, pre and post fall assessment. The PDSA cycle. The PDSA cycle will be implemented on the 3rd floor East Wing orthopedic and spine patients. P. Plan. Form a specific fall prevention team for the project. Analyze falls using fishbone diagram, collect fall-related data on the unit, developed aim and expected outcome, evaluated the current interventions, created educational materials, poster presentations on fall prevention, visual mobility aid signs and visual forms, research latest evidence-based practice to prevent falls, test how reinforcing current fall precautions through educating patients, families, and staff will reduce the number of falls. D. Do. Implemented interventions on the east wing of 3rd floor, assess staff compliance on reinforcement of current fall precautions and the new fall interventions, educate patients and families upon admission, change of shift report, room rounding, and also educate staff during change of shift huddles. Completed patient, family, and staff survey on fall interventions. S. Study. Random patient room rounding to ensure all fall precautions were utilized, weekly feedback from staff, patient, and their families, comparing data pre and post fall interventions, 0 falls on the unit from March and April 2018 with newly implemented interventions and by reinforcing previous precautions. The results from pre-intervention audit revealed a high compliance and great improvement of utilization of current fall preventions and interventions. A. Act. No changes made to the plan as a goal met for a specific aim. Staff continue to follow new interventions and attend weekly huddles for fall preventions. The change cycle employed on other wings of the unit, working with different floors in the hospital to initiate the change throughout the facility by the end of next month. Implementing and spreading the change. Weekly meetings with fall committee, assistant manager, and quality nurse to plan implementation of new interventions. Assess and analyze patient data on pre and post fall. Weekly huddles to educate staff on the importance of utilizing previous and newly added fall precautions. Shared my aim and expected outcome for the project with staff. Started educating staff, patients, and their families on the East Wing on the medical surgical floor. Implemented new mobility aid signs next to patient care boards. Implemented new visual signs that state at risk for fall, don't fall, just call, along with a picture of a call light. After noticing a significant decrease in patient falls with the change project, the project was also implemented on both the west and south wing of the floor. Quality nurse and assistant manager suggested the plan to a different floor of the hospital. I will be working with 6th floor fall prevention team to initiate and spread the change to the different units throughout the hospital. The project is expected to launch hospital-wide at the end of May. Barriers and facilitators. Barriers. Initial non-compliance by staff, difficult to have new interventions approved by management and quality improvement personnel, challenging steps and channels to achieve desired outcome, difficult time coordinating meetings with team members, financial obstacles. Facilitators, education via attaining patient staff amenability, ease of access fall prevention interventions, economic factors such as cost effectiveness, staff acceptability, and patient adaptability. The impact on practice. 0 patient falls for the months of March and April after implementing new fall precautions and reinforcing previous precautions through staff, patient, and family education. After noticing a change on our unit with the newly implemented interventions, other floors are interested in benchmarking our progress. The newly implemented interventions improved our compliance and reduced number of patient falls to ensure better outcomes and reduce length of hospital stays. Staff was recognized and rewarded with potluck as a form of appreciation from the management to encourage and continue improving patient care. Below are references that were utilized for the purpose of this project.